Welcome to Pathology Review for USMLE Step 1. We're now moving on to the second part of our lecture on bone pathology. We will begin by dealing with congenital orders that can affect development of the skeleton. Achondroplasia is the most common disease of the growth plate. It is due to an autosomal dominant point mutation within fibroblast growth factor receptor 3. This point mutation leads to constant activation of the receptor, which leads to inhibition of cartilage proliferation. With cartilage proliferation inhibited, the growth plate's development is inhibited, and what one sees, and when one looks at the pathology, are narrow zones of proliferation and disorganized clusters of large chondrocytes. Clinically, this leads to the classic picture of dwarfism, these individuals having the typical shortened extremities with a normal trunk and an enlarged head. Thanatophoric dwarfism is the most common lethal form of dwarfism, occurring in approximately 1 out of every 20,000 births. Again, similar to achondroplasia, it is a disease of the growth plate. Here again, due to a missense or point mutation in fibroblast growth factor receptor 3, this results in a shortening of the limbs and macrocephaly. Histologically, what one sees is poor proliferation of chondrocytes and disorganization. Unfortunately, secondary to malformation and poor development of the chest cavity, there's respiratory failure and death. Systemic disorders that can lead to the development of skeletal abnormalities include the mucopolysaccharidoses. As you remember from our genetics lecture, this is a group of lysosomal storage diseases caused by deficiencies in enzymes that need to break down various cellular constituents, including dermatan sulfate, heparin sulfate, and keratin sulfate. The fact that these components can't be broken down leads to abnormal hyaline cartilage and poor endochondral ossification. Clinical features here, these patients develop short stature, chest wall abnormalities, and malformed bones. Given the skeleton's role in the development and maintenance of mineral homeostasis, it's not surprising that there are various metabolic disorders that can lead to bony abnormalities. Osteoporosis simply refers to increased porosity of bone due to reduced bone mass. It can be localized just to a single bone, or it can be diffuse and affect numerous bones throughout the body. Now, to remember a little bit about the development of bone mass peaks in young adults. Polymorphisms within the vitamin D receptor account for 75% of the peak bone mass that an individual will achieve. Age-related bone mass generally then occurs at a rate of less than 1% per year. Pathogenesis of osteoporosis is not completely understood. However, it is thought to be due to impaired synthesis of new bone, increased resorption of current present bone, or both. And it can be either primary or secondary due to other causes. Most common forms of osteoporosis are senile, where the osteoblasts have diminished capacity to make new bone, something that is exacerbated by the physical inactivity that many seniors suffer from. Postmenopausal osteoporosis is seen in women secondary to estrogen deficiency, which leads to increased secretion of factors such as IL-1, IL-6, and tumor necrosis factor alpha. Secondary causes of osteoporosis also include steroid therapy, endocrine problems, poor nutrition, and neoplasia. Overall, then, if one wants to look at the development of osteoporosis, remember that your peak bone mass occurs in youth and is determined to a great degree by genetic factors within the vitamin D receptor, interacting with your degree of physical activity and your levels of nutrition. You then have a less than 1% every year decrease in your bone mass, which can lead to osteoporosis through events associated with aging, such as decreased replicative activity of your osteoblasts, increased synthetic activity or decreased synthetic activity of the osteoblasts, and reduced physical activity. For women, menopause can also play a role with decreased serum estrogen, increased expression of IL-1, IL-6, tumor necrosis factor alpha, and increased osteoclast activity. Essentially, the balance between the creation of new bone and the removal of old bone, the former by osteoblasts, the latter by osteoclasts, goes out of whack, and you have the development of osteoporosis. What do you see pathologically? Well, grossly, the trabeculi are thin and lose their interconnections. The patients tend to suffer from vertebral fractures. Here, the body puts weight on the thinning vertebrae, so you have the development of spinal deformities, the development of a lumbar lordosis and kyphoscoliosis. This is just an example of a kyphotic spine compared to a normal spine. Note how the spine protrudes inwards towards the abdomen, and the bottom, the typical sort of lordotic approach, and then the almost hunchback expansion of the spine in the cervical thoracic region. These are just examples of some osteoporotic vertebral bodies. You have the normal vertebral body in the upper part of the slide, and then the shortened vertebral body in the bottom, the shortening due to the osteoporosis, which makes the vertebral body much less able to bear the weight put upon it. Another metabolic disorder that can affect the development of bone in an individual is Paget's disease. This is a skeletal disorder that's marked by disordered bone resorption and bone formation, where you have essentially osteoblasts and osteoclasts acting no longer in sync, but literally against each other, with constant creation and destruction of new bone. Paget's disease is divided essentially into three stages: an osteolytic stage, a mixed osteoclastic osteoblastic stage, which creates the characteristic mosaic pattern of the bone that most people associate with this disease, and then a burnt out, or what we term osteosclerotic stage. Paget's disease has an interesting history in that when Paget initially described this disorder, he thought it might be due to some sort of underlying viral infection. This theory was poo-pooed for many years, and Paget's theory was considered to be untenable. Now we have come full circle and are beginning to give his theory new credence again, as it's considered that Paget's disease may be secondary to a viral infection, particularly infection with paramoxavirus. The pathology, again, there is a mosaic pattern within the lamellar bone. You have numerous resorption pits or Hauschup's lacunae filled with osteoclasts, and then bone eventually replaced by a loose connection of connective tissue. This is just an example of a long bone where you have all three phases taking place: the osteosclerotic phase, the mixed phase, and the osteolytic phase. You see them represented by the numbers 1, 2, and 3. 1 represents the osteosclerotic or burnt out phase. 2 represents the mixed phase, the mosaic pattern that one would see with osteoclasts resorbing bone, osteoblasts trying to lay down new bone. And then at the top of the arm, the area labeled number 3 is the osteolytic phase, where osteoclasts are acting with abandon to resorb bone that has been laid down. This picture is simply an example of the mosaic pattern and perhaps part of the burnt out phase, the osteosclerotic phase, that one sees in long-term Paget's disease. Clinically, what you're going to see in these patients, well, with all the destruction of the bone, it's not surprising that alkaline phosphatase will be elevated. Focally, the areas that tend to be affected are bones of the pelvis, spine, and skull, so think the central spine. The patient can develop pain, not surprisingly due to the microfractures. Remember all the emphasis that we put in our previous discussion of osteoporosis on compression factors of the vertebra. You can see similar sort of effects here. You also can see bony overgrowth that may compress spine and cranial nerve roots and produce neurologic difficulties. The dreaded complication of Paget's disease that occurs in approximately 1% of cases is the development of osteosarcoma. And then these patients also, with the new vascularity that develops, can get arteriovenous shunting and high output heart failure due to this hypervascularity, where the heart essentially can't keep up with all the new demands from the new blood channels that have formed within the bone. Osteomalacia rickets. This is defective bony mineralization seen in any population where there's a lack of vitamin D. In adults, we term this osteomalacia. In children, this is termed rickets. You can learn more about this by following the nutrition lecture that is part of the pathology lecture series. The kidney has a complex interaction with bone, again, with the maintenance of various levels of minerals within the body. There is a form of bony abnormality that is due to renal dysfunction called renal osteodystrophy. This is essentially a form of rickets or osteomalacia secondary to chronic renal disease. What occurs is you have chronic renal failure for whatever reason in a patient, which leads to disorders in phosphate metabolism and leads to the patient developing hyperphosphatemia. This hyperphosphatemia leads to hypocalcemia due to the high phosphorus binding calcium and a lack of conversion of vitamin D. This combination of hypocalcemia and hyperphosphatemia results in a secondary hyperparathyroidism. The PTH secretion from the secondary hyperparathyroidism stimulates osteoclasts, and you have further bone resorption. Now, this sort of effect can be primary or secondary. The PTH will also activate osteoblasts, so you end up with the entire skeleton being affected by this, what will end up being overall resorption of bone. If left untreated, you have the development of what is termed von Recklinghausen's disease of bone, where you have increased bone cell activity, peritrabecular fibrosis, and all surrounded by masses of what was termed brown reactive tissue due to bleeding and take-up of hemosiderin by macrophages. This ends the second part of the Falcon Pathology lecture series in the review for USMLE Step 1 on